Okay, questions and discussion among you guys. Bert? Good question. So automatic external defibrillators, which this building has, which would be used when the heart stops. So the question is, should that be done, I guess?
Yeah.
Well, I definitely don't want to come across as being anti-CPR.
Oh.
I don't want people, though, to be disillusioned about what the likelihood of success is. It's the only thing we have. If somebody drops, do you know what the indication, the medical indication is for CPR? A patient has to be dead. Their heart has stopped beating. That's how we define death. It's one way. So they're dead. This is the only procedure that we have that has the possibility of bringing them back. It's not a good possibility, but it's the only thing we have. Now, in a setting like this, we don't have time to get to know the patient, to get a lengthy history on them, to understand how life is going for them. We have only the decision, are we going to go ahead or are we not? And so the default is always do it. That's how we think medically. We train the population to do it. We're all trained. We've all done it a lot. And it's because it's the tool we have. We wish we had better tools, but we don't.
Ken, is there, I'm sorry, I'm just going to say that when the instruments are here, rather than wait for the ambulance to come and everything, the success rate is much better, isn't it?
Yes. It's better. I don't know that I would apply the word much. It's better because the only thing that we're doing, maybe I should speak to the microphone. The only thing that we do when we do CPR is we're buying time until we can shock the person. That's the only thing we're doing. So if you're up in the mountains somewhere, like I often am in the back country, and it's hours before you're going to get an AED or you're going to get paramedics, I mean, you can do it, but it's going to be hours till you get it. In reality, you need to get the shock within about 10 minutes. Sometimes it goes beyond that, but generally speaking, you have a very short period of time. 75% of people who go down do not have a rhythm that can be shocked back. So you're going to lose, under the best of circumstances, you're going to lose 75% of people. So you're trying to get that other 25%. But in a situation like you asked here, we don't know who the people are. If somebody goes down, the three of us are going to bully all over, getting to them, and trying to get things going, because that's all we have.
Yeah, I just want to make clear too that to be talking about CPR in situations where people have advanced illness and are going to die of some kind of organ failure is a completely different scenario than what CPR was ever created for in the AEDs in particular. That if you take a otherwise healthy person and they happen to have an irregular heart rhythm that causes their heart to stop, if you can intervene with the AED and get them back, they can be back 100% healthy. And so that is truly life-saving. So yeah, I wouldn't want anybody to walk away and say, well, I don't want to shock anybody, because that doesn't work. I hope we make that clear that it's a completely different situation.
So, I don't mean this competitively.
That's all right.
No, last week we passed a policy at Sharp, and it's now officially approved that we can use the phrase DNAR, do not attempt resuscitation. But included in that policy for the hospital was the next step in this, which you should be aware of, which is within, I bet, 2 years, all the policies will now state that the physician's order will be AAND, allow a natural death. And to me, that's where the paradigm shifts. We get away from the magic, we can rescue everybody with this attempt, to understanding that we're facing illness in the course of a lifetime that has a beginning and an end, and a doctor is fully competent to give an order to allow a natural death in circumstances that involve hospitalization. But the culture of the hospital has not yet accepted that.
So Jeff, you're saying that that's an option that a physician has to sign an AAND?
Well, AAND means the same thing as DNR or DNAR, but it's a paradigm shift in terms of the doctor's in charge and he can choose or not choose, whatever. It recognizes that we're in a life course that has a serious illness, and the patient, the family, the surrogates, and the doctor make a decision to allow life to take its natural course, but it's the same thing in fact as DNAR. It's a cultural and cognitive shift. It's a different perspective. The doctor's not in the driver's seat. Life is. And so it comes, I would much rather talk to a patient in terms of allowing life to take its course than to say, well, should I thump on the chest and do CPR and all those other things. It's a different flavor conversation.
Yeah. It's my understanding Children's has adopted that terminology rather than do not attempt resuscitation in a terminally ill child, so they do use that terminology.
And they put it in the pulse form now too.
Yeah.
The new pulse form. We haven't heard about pulse, by the way.
Oh, well, we have back there, and this is from our sponsor here, we have a collection of advanced directives and versions thereof. Would you hold it up, Bob? What do we call it? Documents?
Documentation for issues and end-of-life issues.
Yeah, so Bob just revised that so that we have up-to-date forms, including a new pulse. If you've already bought that booklet of directives from us, then we will give you a new post. I don't know if they're on sale or not, but anyway, yeah, we are aware of that. Yeah, back there.
They don't know what it is.
The post, physician's orders for life-sustaining treatment is an advanced directive that is preferably used for people at the end of life. I see a question from Karen. Hold on just a second, Karen. Yeah.
I don't have.
That's a really great point, and it's a complex one. There are several lines of thought that kind of lead in the same direction here. There is a style of thinking that says it's not our job to tell the patient what to do. It's our job to give them information so that they can make an informed choice. But the line that's drawn is we don't want to be pushing people into things, particularly when it's involving their death. And so there's a lot of sensitivity to the concept that we shouldn't be advocating anything. We should be giving information that allows them to ask the question. Now, that having been said, I think that is sometimes a weak argument. And specifically, when a patient comes to me and they present their information, I examine them, I look at the records, do tests, whatever. They have come to me because I assess that they want my opinion. They could have gone to the guy down the street, but they came to me. So I think they want to know what I think. So I have advocated that we should tell them. Now they may choose not to accept our opinions, and that's certainly their place to make whatever decision they want. But they came to me to ask the opinion, and I feel an obligation to give it to them. But this is controversial. And I've held discussions with groups of physicians where I have gotten a lot of pushback on that. They feel like you're pushing people into things, and you also run into situations where if I'm an employee and my company benefits by you dying, but instead of providing really expensive care, that there's a conflict of interest. Now, I think the best way of dealing with conflicts of interest is to expose them and lay them out so that everybody understands, what it is. I think we as physicians, we have ethical obligations to our patients that should supersede any of those conflicts. But they exist, and they're not always superseded, and there are problems. So I can understand why some physicians would feel that way.
Good.
Yeah.
I have a different answer to your question. It has to do with the word fiduciary. There's an admirable default in the practice of medicine, which is I'm in a trust and fiduciary relationship to this sick person, and the default is always to preserve life. And I think that's an admirable and appropriate stance. So what we're talking about are subtleties. Subtleties of your personality, your disease, your prognosis, your family situation, and what you think is best for you, and what the physician's perception of your disease is, and what the possibilities for intervention and management or cure are. And so none of this is black and white, and it's a process. And again, the default, the simplest thing to do in medicine is always to do more. And what we're talking about is circumstances in which that might entail suffering, both for the patient and for the physician and his staff. One of the things I find in my consultations in the intensive care unit in the hospital is we have an epidemic of what's called moral anguish among the nursing staff, which produces demoralization and high turnover, where they feel that the intensive care doctors, in their quest for preserving life, are causing frail people with poor prognosis to be tortured and harmed and pained in the quest to preserve their lives. And this is an epidemic. And doctors have yet to feel in their gut the consequences of this epidemic and do something about it. But I would not fault them for their fiduciary responsibility to preserve life unless asked otherwise. And so what this discussion about is to educate you about these subtleties, so in the appropriate circumstances, you can stand up and ask otherwise. The end of life, the living will, the post form are mere documents that facilitate that. Someone has to be there to see how this situation calculates out for you. And there's one other factor that none of us have yet mentioned, which is, for the doctor in the emergency room or the intensive care unit, your experience or your loved one's experience is just another one of the 12 they're dealing with today, or their 50 that they're dealing with today. But this is a once-in-a-lifetime, never before thought out, tragic, worrisome, anxiety-producing, oh my God, experience for you and all your loved ones. And it's inherently asymmetrical. And again, coming to a meeting like this gives you some knowledge that helps you deal with the eventual situation when it arrives, which you wouldn't otherwise have.
Thank you.
I'd like to call on Karen Van Dyke, the founder of the Death Cafes in San Diego. And if you want to put in a commercial for the Death Cafes, Karen, that's fine.
Here's the time say, yeah, we got cafes
you haven't, make sure you go.
Yeah, they're amazing. I wanted to give you a quick personal story that's been very recent. Last Sunday on the Pulse, last Sunday I found myself at the ER room with my aunt, 102, and she wasn't responding at home, and so I thought I should bring her in. And so the ER doctor, they took tests, and he came to me and he said, hey, listen, I think we need to put a pick in her neck because we need to give her antibiotics because she has an infection. And I handed him the Pulse, physician's orders for life-sustaining treatment. I handed him her Pulse, which he did back in March. And I said, you read this, and then you tell me, because you're the doctor and I don't know, if her Pulse aligns with what you just said. And he read the Pulse, and he looked at me, and he said, no pick. And prior to that, he said to me, if she doesn't get the pick, she's probably not going to leave the hospital. So I'm encouraging every single person in this room, if you don't have a physician's orders for life-sustaining treatment, that beautiful pink form over there, I highly, highly recommend it because it's signed by your physician. So think about it. You've got a physician standing there, you've got a physician's order in that Pulse, you've got peer-to-peer looking at things, not attorney to doctor. Makes a difference. At least it did for me.
So is your aunt?
She's alive. We're currently, I've been texting, we have a situation going on, but I think we're just going to bring her home, so we're going to let make
the pathways seem to open up. Any comments on that?
Yeah, so the question is the greatest impediment to a death with dignity often is the family.
Yeah.
Yep.
Interestingly enough, in California, there's no hierarchy of surrogates in the law. It's not your wife, then your brother, then your children, or whatever. So it's whoever has your best interests at heart. And again, I think what you point out is that basically, if you write documents and establish your wishes, your own personal wishes in advance, that short-circuits those other concerns. And all of us deal with cases where Aunt Susie, who hasn't seen you in 5 years, is in Iowa and is the only contact we have, and she doesn't want anything done to curtail suffering. We all see that every day. But the way to avoid that is to have your own wishes well stated.
Although I will say it, ultimately, physicians, and this usually doesn't come up when people are in the hospital, but you know, as far as choices in the hospital, they're going to tend to listen to family members who are there talking to them more than they will listen to a document, unfortunately. So yeah, ultimately, the document really has to be supported by your family members in most cases that I've seen, including what happened with my own family. But, so, yeah, I think, but for what we like to call aid and dying, that's generally going to be not in the hospital setting. I think you're asking that, or your comment or question is it families that impede that process? Which I would imagine would be the case, that probably in most situations that you really need to have your family or close friends or your closest circle of support to be on board with that choice, I would imagine.
This issue comes up in a lot of different areas in medicine, and one that I only recently found out about has to do with the issue of transplant. When a person is dying and harvesting an organ and so forth, you can sign all the documents you want. Anything. If, when the time comes, your family doesn't agree, it will not happen. It doesn't matter what you've signed. So what your driver's license says on the back doesn't matter. They don't agree, it's not going to happen. So we sometimes refer to these situations in a hospital is there isn't a hierarchy, but there is a hierarchy of volume. And so sometimes the loudest person is the one that wins or threatens the most.
Everybody hear the question? A doctor who is not DNR necessarily, but a doctor who has an Alzheimer's or cancer diagnosis and wants to hasten their death, do they stash away drugs or what do they do? I was going to ask you the same thing. That's what I thought when I started to read the article, how doctors die. Oh, they must store up Seconal. No, that's not what you said. Probably have veterinarians die.
I actually don't have any particular insight into that. That's not something that I've seen anything that has really been studied. So I don't think we have any scientific information on it. But I took your question as a little bit differently. And it is true that when we hold these discussions about end-of-life issues, there's really a tendency to focus on cancer. But in actuality, the more difficult situations tend to be degenerative neurologic conditions. We have lung conditions, heart conditions, all of which are terminal. And it's probably less well-defined in those situations. However, to answer your question, which is how do physicians feel about it, this was actually answered in great detail in the Gallo paper that I mentioned. They went through and asked a lot of very specific questions about such things as Alzheimer's and so forth. And it pretty much was of a pace, which was, would you want, one that surprises people is, would you want antibiotics if you got any infection? Most answered no.
I think the point of the question was, you're talking about refusal of treatment, and she's talking about preemptive measures to take when you know something's going to be pretty terrible that's going to happen to you.
Yeah,
so treatment to
we were
refuse.
talking about this. There are no statistics, for instance, in the state of Washington or Oregon about how many people that choose aid in dying are physicians or members of medical families, nurses and so on. So the statistics are not kept. As Fay has mentioned, it's been at least 25 years that I've been involved with the Hemlock Society, and I've done a fair amount of public speaking. And I would only say that I recall more than a few times that physicians have called me and asked about a loved one who had, for instance, ALS, and said, how would you help their suffering to stop? And so the inquiries are there. I mean, in the old days, when you became a medical student, people called you and asked where you could get an abortion. Now they ask you about questions at the other end of life. But those inquiries do come forward. But there are no statistics that would be...
but the Oregon law wouldn't really address those issues of what's going to happen if you're not terminal, but you have a horrible diagnosis and you know it's coming. That's really the most important issue that we have to deal with now, I think. Lynette, were you going to say something?
No, I was just going to say that, you know, if there are physicians that do this, we have no way of knowing that unless you happen to know somebody, because there's no way to collect that data. It's all would be under the table. So,
and we're not necessarily talking about helping a person die right then and there. We're talking about how do you get the means to preemptively end your life before it gets too bad. And the physician may not even be the persons to do that. Maybe the veterinarian or somebody. We don't really know. Yes.
Yes, thank you.
Okay, what's palliative care compared with hospice care?
So, hospice care model was developed first, and that was originally developed as supportive care for terminally ill patients to do everything to maximize their quality of life and bring comfort at the end. And when Medicare came on board with this as to how to reimburse for it, they made the somewhat arbitrary determination that someone is terminal and qualifies for hospice if they have 6 months or less to live. They had to draw the line somewhere, so that's where they drew it. We're not very good at predicting that specifically months of survival, but it's the best we can do. So hospice we think of as multidisciplinary supportive care in the last 6 months of life. What has then cropped out of the hospice movement was the palliative care movement, which really is an extension of the hospice model to anybody with chronic, severe, progressive illness that needs a lot of support and care, and that would be palliative care, because we realize, well, you know, someone might have maybe even a few years of survival, but really needs a lot of pain management, really needs a lot of psychosocial support, needs resources to be taken care of, even while they're maybe getting chemotherapy or radiation therapy. Because the other piece of the hospice model was that you had to choose. You know, you don't get hospice care until you forego any life-extending treatment. So you can't. You can have your chemo or you can have hospice, but you can't have both. Whereas palliative care was introduced earlier on in the trajectory of illness and could be given concurrent with other treatments. So if a seriously ill cancer patient wanted to have chemo because there was some benefit, but also wanted good supportive care, they could have both. Right now, the difficulty is that there's not a good model of reimbursement for that. So people have struggled with ways to sustain that care, maybe with someone who is getting chemotherapy and all the other treatments. Medicare just doesn't have a good way to reimburse that because it's not in the hospice funding. The best they can do is do the home health model, but that means in order to get palliative care, you have to be homebound. And so it's still kind of, I think, an uncovered gap in the system.
Many can the situation be justified?
I've written a couple of articles in our newsletter.
Let me do that.
Yeah, go ahead.
That's a misunderstanding. A paramedic team that comes to your house because you're unconscious on the couch or whatever, they're not going to find paperwork, but the reason for the pulse, which the lady down here described as pretty in pink, is because you put it on the icebox, and the paramedic crew is trained to look for the pink form on the icebox, and they are under central station control, and their standard operating procedures are to look for that and obey it. But the prolonged paperwork is not something they can ferret out. But the reason for the post form is to be there when the paramedics come to your house. They look for it. And they're supposed to transfer it to the emergency room.
Jeff said, sorry, Jeff is showing his age. We don't have ice boxes anymore. But we could use one here, actually. But if you're not next to the refrigerator, or if you're at the grocery store or church or something and you need CPR, it's much better to have a necklace or a bracelet so that the EMTs immediately identify this, because what you have in your advance directive, they don't have time to read.
But if I can comment, I actually
Who's talking?
Me. I have to say that that's been my experience, and I'll just share my personal experience of helping to take care of my aunt who became very frail and was in assisted living and was cycling in and out of the hospital, and finally became tired of that and really wanted to just be kept there and kept comfortable and not go back to the hospital or the ER. I was working for a hospice. I was implementing the Pulse project in San Diego County. I had all my ducks in a row to help her, and so I got her enrolled in hospice. I had her Pulse form stuck on her ice box. And she was in a little one-room room, and so she wasn't very far from her refrigerator, and had all this in place. What happens? You know, one poorly trained medical assistant in the facility wanders in, finds her unresponsive in her recliner, which is how she would have liked to have gone. What does she do? She calls 911. they whisper off to the ER and the resuscitator, all completely against what I had set up. And so yes, I understand what you're saying, and unfortunately those scenarios happen. The only way they stopped was when I physically arrived in the ER and physically blocked them from continuing to try to resuscitate her. And unfortunately the pulse did not work because people ignored it. Now legally they violated the law by ignoring it because there is a legal mandate to honor the pulse. So, you know, could I have sued the paramedics? Probably. And maybe that's what it's going to take, is some lawsuits of violating people's pulse.
Yeah.
Fay, I have another answer to the question. And again, this is sounds mundane, but at Sharp Hospital, after many years of work, we've got the IT people to put end-of-life documents in the banner at the top of every patient record. So that if you arrive and you're a known patient to that hospital, you arrive in the emergency room, the doctor can click on that and can immediately see your forms. So again, it's part of your responsibility is, I mean, again, if you're found down at home, they might take you to Mercy, but nonetheless, or you could take your post form and you'd say you want it on record at every hospital in the environments. But having that prominent at the top of every medical record is a way to create a system to beat that oversight.
Thank you. We've got that too. It didn't work.
But unless you're somewhere else, there's no documentation. I want to talk to Lenny.
Okay, so I'd like to have one thing cleared up. My understanding on the pulse, say take somebody in their 80s, normal, pretty decent health, goes to the doctor a couple times a year, no serious illnesses. And all the paperwork with the living trust and all of that paperwork has been done. But my understanding was that you would not fill out a post and talk to your doctor about it and get him to sign it unless you had some kind of critical illness that would indicate you needed to do that.
Okay, that's a very good point. Let's take a vote here because I get that confused too. And at our place, Gene, they told us when you're 18 you should have a post.
No. No.
I mean, I don't think so. What do you think, Ken?
No.
No. So when
should you have it?
Probably when you get
So,
to Medicare age.
Generally,
Medicare age. Oh my God.
Generally it's targeted towards people who are at a point in their health and life where they want some limitation of treatment. It's not dictated by age at all. So generally we train people to think about using pulse when people are approaching maybe their last year of life. Okay? So if you're 85 and healthy and you anticipate living to 100, you probably don't really need to want to think about having a pulse.
Thank you.
Now, having said that, I have some 85-year-old, I have a woman in my practice I've had for 20 years. She's 85 years old. She's vital. She lives independently. She runs a research lab still in town. She's amazing. She has a pulse form that says DNAR because she says, I want to be fully functional till the day I drop down and I want people to just leave me alone and let me go. And that's her choice, but that's not really what it's targeted for necessarily.
Thank you.
What's the difference?
Okay. What's the difference between an advanced directive and a pulse? These are questions I think that are on all of our minds, so this is a good time to find out.
So the advanced directive is the document that everybody from the age of 18 up should have, like the La Crosse, Wisconsin community that's implemented, having everybody fill one out. And the main thing that the advanced directive does is, although you can make statements about your wishes of care in there, the biggest thing it does is designate who your surrogate is. If you suddenly lost the ability to make your decisions, who would you designate to make your medical decisions for you? And that's very, legally, ethically recognized as knowing who to direct the questions to and the choices to represent your interests. The pulse form doesn't designate that. That is a specific order form for medical treatments. It's ordered by a physician who signs it. So it's much more concrete towards treatment decisions. It allows you to designate your code status, your preferred intensity of treatment, like you want everything done to go to the ICU short of being coded, or you just want to be kept comfortable, or you don't even want to go to the hospital. do you want artificial nutrition, hydration? So it's very concrete medical orders. And that really helps to supplement the advanced directive, which really serves the different purpose of designating your surrogate. The other distinct difference is that an advanced directive has to be completed by the person who, when they have the ability to make their own decisions and choices. Once they lose that, they can't do an advanced directive. Whereas the POLST form can be completed by a surrogate or a family member for somebody who does not have decisional capacity. So say you have a family member who is now has dementia that's advanced to the point where they can't make those choices. Maybe, you know, you think that at that point it would be inhumane to try to code your loved one, but they can't fill out an advanced directive saying that. You can complete their POLST form with their physician and designate that. So that's a very valuable.
Coding sounds like something from the CIA.
Resuscitate, attempt to resuscitate.
One more question that increased, because it's generally 2 weeks.
It has not increased a lot. And this is definitely an issue. I mean, the eligibility is 6 months. And there's no doubt that the earlier you get in, the better things are going to go. There's no doubt about that. I think what's happening is that we're going through a transition where physicians are getting their toes wet, who were uncomfortable with the concept of hospice. And so what tends to happen is you tend to do it when it's not going to matter. So you put somebody on hospice that's going to die anyway, well, they should be by definition, but relatively quickly. And so there's not a perception that there's a liability issue. And see how it goes, and do a few patients like that before you start to put people on 2 weeks ahead of time, that sort of thing. I think that there's a bit of that that's going on. And new people in training, coming out of training now, are I think, a lot better trained in this than the people in my generation who got no training. And so they kind of had to learn it on the fly. And so I think the older group of physicians are experimenting a little bit.
I have a complementary and opposite answer. And again, I think in speaking to this audience, I want to go down to the real subtleties of life. And getting a patient to, I agree 100%, I think hospice is totally wonderful in the context of serious fatal illness. Whether you're talking about social support, or nursing support, or medications, or health aides, or getting a bath, or anything. It's just a wonderful organization. And it's worth mentioning that as a Medicare benefit, 100% of hospice costs are paid 100%. You have no copay, no deductible. Okay? But choosing hospice is the patient and their families are negotiating with God about how long they're going to live. And they have to make a decision that I accept the fact that I'm going to pass before I will sign on to hospice. I mean, many's the time I would recommend hospice, and the retort would be, that means I'm going to die soon. It doesn't necessarily mean that. I've had one patient on hospice for 3 years. The hospice probably got in trouble, but you know, prognosis is inexact. But it's the patient's mentality, the family's.
Okay. I want to thank Dr. Ken Murray, Dr. Jeffrey